New York, the Medicaid program and the public health programs both are within the state health department. So that's been an advantage for collaboration for us. There's a deputy commissioner over the Medicaid and other health insurance programs, and my role was the deputy commissioner over public health. So we were parallel within the organization, both reporting to a state health commissioner. So that has been a great advantage. We've done a lot of work between public health and the Medicaid program over the years. A prime example is with our AIDS epidemic in New York, we developed special Medicaid rates even a couple of decades ago. So there's a long history of collaboration between the two programs in New York. I think the primary collaboration that's going on today is very exciting. New York is an accredited state health department. We developed a state health improvement plan, or SHIP. We call it the Prevention Agenda. And we did that several years ago before the state really got into negotiating with CMS a delivery system reform incentive payment program waiver, a DSRIP waiver. So New York is a DSRIP state. And the exciting thing about that is that the public health measures, the population health measures in the DSRIP plan are pulled directly from our state health improvement plan. So there's a direct link in the department between our public health efforts, our health improvement plan that we're working on in the community with what's happening in the DSRIP waiver. The DSRIP waiver's primary goal is to reduce unnecessary hospitalizations in the state in the Medicaid program by 25% over 5 years. It's a very ambitious goal. If it's not achieved, the partners and the players out there that are getting DSRIP funding will not get the full funding available to them. So there's a very big incentive. And where population health comes in is that there's one of the 4 domains. So let me back up and just say, in the New York DSRIP program, they have formed locally around the state performing provider systems, or PPSs, which are coalitions of hospitals, clinics, community organizations that cover a geographic area and are responsible for reducing costs and reducing unnecessary hospitalizations in the Medicaid program. So, for example, public health efforts could certainly come in. If you're successful with smoking cessation, you'll reduce hospitalizations for heart attack, for pneumonia, for respiratory illness. If you have home visiting for asthma, you can reduce hospitalizations for asthma. So there's a very direct relationship between our public health goals in New York and the goals of the DSRIP program to reduce Medicaid costs and reduce hospitalizations. So the program is just in its beginning stages. 2015 is the first full year of the 5-year project, so there's not yet any, we don't yet have any outcome data related to interventions within the DSRIP program. This is the first year of the program. It's just the local projects have just been up and running since the beginning of this year. But in year 2, 3, 4, and 5, the hope is that we'll be able to really demonstrate savings in the Medicaid program, and that the public health community will be part of contributing and be part of that success. I think in terms of challenges of the program, obviously I mentioned we're fortunate to be in the same department as the Medicaid program. The Medicaid program in New York is somewhere in excess of $50 billion a year, and our public health programs are a small fraction of that. So we have to continue to make the case for public health and to stay engaged and keep people honest, to keep us engaged in the process. So that's I think a normal thing when you have 2 very different sized programs and entities. But we do make an effort to sort of stay at the table. We've actually convened all of the public health programs on a regular working group with our counterparts in the Medicaid program to be sure that we're on track, that we're communicating, that we're being involved in any decisions that are making there. So that's been a good way to keep public health engaged in the process. In terms of lessons for other states, I think each state is going to be different in terms of their organization. I think, as I mentioned, we're fortunate that Medicaid is in the health department, but even if it wasn't, I think if you have a strong public health program, it's helpful. I think it was helpful for us to have a state health improvement plan fully developed and vetted and as part of our accreditation process. So we had that available to share with the Medicaid program, and they, I think in their negotiations with CMS, could say, look, here we have a fully accredited health department with its state health improvement plan ready to go. The measures have been selected through a process that involves stakeholder input. So let's just adopt this as the public health components of the Medicaid waiver. And I think that any state that's able to go to their Medicaid program and say that is in a much stronger position to have the public health that's really exactly coincide with what the Medicaid program is doing.